Hi, I'm Dr. Gerald Deas. Welcome to Health Center from Downstate Medical Center. You know, when you look at it. When you look in the mirror, you have a face. Everybody's born with a face. Everybody's face almost is different in a sense, almost like a fingerprint. Racially, it's a fingerprint. Whether you have a small chin or a wide chin, or you have a up nose or a down nose, it's all a face. And the face tells a lot about the person. There's a whole book written on the face and the message that the face gives. But there's some faces that are born that are not all together. And this is what we're going to speak about today, a face that as they go through the 9 months and that little face is formed, little do we know, as you know, even as doctors, just what's taking place. Sometimes you can tell through certain x-rays and things like if you suspect something, but generally what comes out of the womb with that little face, Lord does it, it went through something in that 9 months. In fact, every time I look at a baby in the nursery, I'm always amazed at the ear. The ear to me was the most complicated thing because it has all these curves in it and things like this. So some cells have to develop and some cells die to give you all this curvature. In fact, if you look at the ear, it's an upside down baby. Here's the head and goes right on around here, you know, and so forth. So we have this face. Unfortunately, in war and other places, faces get injured. Sometimes birth defects, there are birth defects. Here at Downstate Medical Center, we have a department that's dealing with facial things that happen during the 9 months that have to be corrected if that person is going to have a normal life. And leading that department, Reconstructive facial abnormalities, is our doctor here that I've known her for quite a while, and so glad that she has joined the staff here because it's so hard to find qualified people in this particular field. But I want you to listen carefully and see carefully and not enjoy, but understand what it is to be a person that's chief of that type of surgery. Good morning, Dr. Butts.
Good morning. Thanks, Dr. Deas.
Yes, it's good having you here today. You know, I just have to give you a look. People looking at you on the screen right away are going to say, well, how old is she? Be a doctor? You know, I know you get that all the time. They look at me, they say, he is an old doctor, but with yourself in the sense, you're a young person who has had a career and now at Downstate heading up that department of reconstructive surgery on the face. But just a little background, where'd you come from? Who are you? What about your family? Just so we can, your family have this forever.
Well, I'm a native New Yorker.
Right.
Grew up in Queens mainly, and left New York for a few years for college and medical school. I did both of those at Yale. Mm-hmm. And then I came back to New York for my residency in otolaryngology, also known as ear, nose, and throat surgery at Albert Einstein Montefiore Medical Center in the Bronx.
Right.
And then spent some extra time subspecializing in facial plastic surgery and did that fellowship at S.U.N.Y upstate in Syracuse.
All right.
So got to upstate New York for a little while and stayed on the faculty there after fellowship. And what was really gratifying about that experience was the exposure and training to dealing with the kind of anomalies that you were talking about in the intro, children born with congenital anomalies, mm-hmm. birth anomalies essentially. Mm-hmm. And like you said, that happened for a variety of reasons. Some we understand, some we are still learning about and trying to understand better. Mm-hmm. But you know, these are children that face a lot of challenges from day one. And the ability to identify them and help get them the resources that they need, which are many. There are surgical resources, there are nursing resources, and a variety of multiple other clinical services that they need in order to be rehabilitated properly, just like you said, so that their lives can be as normal as possible.
Right, right. But you know, is there any genetic thing connected with it, or yeah, maybe?
No, as I said, there are many causes, and one of our initial goals, once that diagnosis of, say, like a cleft lip or palate has been made, is getting to the bottom of what the cause was. Mainly so that we can know for the child if, say, there's a syndrome that is associated with the cleft, so that we can anticipate any other health problems the child may have.
Right.
And also for some genetic counseling for the family, because the family may want to have more children, they may want to grow their family. So they need that information so that they know how to proceed with having more children if they want to do that.
Right. Is it any way connected to poverty, or say poor nutrition and things like this, or is there any relationship to
That's
that?
an interesting question. So there certainly are exposures that put families more at risk, mothers more at risk of having a baby that's born with, say, a cleft. And, you know, again, there are a variety of other anomalies of the face that don't involve clefting. You were talking about the ear.
Yes.
That's a condition one condition is called microtia, where the ear is either almost wholly absent or very small or constricted. But you know, in terms of clefts and things like that, we know that, you know, the face is forming very, very early in gestation, actually the first several weeks. And by about the 7th or 8th week of gestation, many of the structures that we would recognize as, say, the lips and the palate are well on their way to forming. So knowing that information means that if there are some unhealthy exposures, things like smoking is a huge, huge culprit.
The mother's smoking. How
Alcohol
about smoking in the house?
Well, not as potent as secondhand smoke.
Secondhand smoke. Right.
Not as potent as mom smoking, but certainly, you know, all of that kept to a minimum is ideal. But we know that mom smoking, alcohol intake, particularly during that early critical period, there's certain medications which, you know, the GYN or the obstetrician rather would counsel mom about. So, you know, to the degree to which, say, a mom's socioeconomic level doesn't allow her to get into prenatal care, where she's getting that education and being told, you know, smoking, alcohol, don't do these things, I think there's a relationship there. But no, generally just prenatal care and access to health care is a humongous bonus, particularly for mothers like this. And if you're an at-risk mom, you've already had a baby with a problem, you definitely need counseling.
Well, you know, you think of the poor person that doesn't get prenatal care until well on the way.
Sure.
You know, it's amazing that all those things you're talking about forming so early, sometimes it's too late even then when you think about it.
Right.
So we're talking about prenatal care as soon as you, say, miss your period or what have you, that you're pregnant. That's time to start all this, taking things out of the diet or taking things out of the environment.
Or putting things in the diet.
Or
So for
diet.
instance, you know, a major public health achievement was understanding the relationship between folic acid supplementation
yes.
and the reduction of neural tube defects.
Surely.
And, you know, the fact that that has happened widespread in the U.S. since the early 90s, and then in the later 90s, you know, cereal grains have been fortified. That's mandated in the
right,
U.S.
Sure.
Has led to a major decrease in neural tube defects. So adding things to the nutrition of expectant moms is also helpful from a protective standpoint.
Right.
And there's research that's looking into the possible protective benefit of folic acid supplementation on reducing clefts as well. The relationship isn't as clear cut, but there looks like there could be a protective benefit. Overall, just optimal nutritional status is good for mothers generally. So,
yes. Well, you know, I did a lot of work in the eating of algal laundry starch by African Americans during their pregnancies and things like this, and it's we know it definitely removes iron, but if you think of all the other nutrients that it possibly could be binding with also, to give that a greater chance of happening. Have you seen any relationship of clay eating or say algal starch eating, or has anybody looked into that?
Not that I'm aware of. No, I'm not aware of that.
All right. Well, because like you say, nutrition only takes one thing: folic acid.
Right.
To close the tube,
Right.
and
Right.
form the bone and everything else there, and so. But now, when you go to foreign countries, and before we even get into that, what made you get interested in going to foreign countries to correct some of these problems? And there must be a myriad, there must be thousands of people all over the world with this problem.
So, one of the professional organizations that I'm a member of is called the American Academy of Facial Plastic and Reconstructive Surgery, and one of their kind of hallmark humanitarian programs is something called Face to Face, and it has two arms. One arm is helping doctors organize trips, international mission trips abroad, where they bring their surgical skills with a team. Oftentimes, not just a surgeon will go, anesthesiologists, nursing staff, everyone will go together. They'll identify a hospital, in a town where patients are just not able to get access to fairly sophisticated reconstructive procedures that are needed, and will go for certain periods of time, a week, 2 weeks, operate on patients, and then return home, but maintain follow-up with that the core group of doctors that are there.
Oh, I see.
And oftentimes, physicians that I know will go back to the same hospital year after year, sometimes multiple times a year. So, it seemed just like another really rewarding way to bring knowledge and expertise to parts of the world where maybe patients weren't able to get that. And so I joined up with some colleagues, and most recently was lucky enough to participate in a trip to Rwanda with several other surgical colleagues from different hospitals in the U.S. So it's very gratifying and very eye-opening to see what patients have available to them in other parts of the world.
Yes.
Kind of how fortunate we are here in the U.S. Despite some limitations that many patients face still, there are places in the world where patients, just because of lack of healthcare infrastructure, end up having delays in treatment where, they miss certain really important windows where they could get benefit from reconstruction. And this is particularly important in little kids.
Yes.
Where, if you don't, if certain operations aren't done at certain critical periods, patients won't get that same benefit if the surgery's done later.
Yes.
So that's very, it's kind of humbling to go somewhere where you're used to working somewhere where there's certain, we use this term standard of care often. This is the standard of care, but it's a standard of care in the US. It's not the standard of care when you go somewhere where there's one doctor for, an overwhelming number of patients. So.
I see. In African Americans here, is there any greater incidence of this particular condition?
So it's interesting. When I'm actually right now working on a research project with some colleagues from the School of Public Health, and we're really interested in looking at some of these epidemiological factors that either represent risk factors or protective factors in the development of a cleft in a child.
I see.
And so we're looking at a variety of factors, one being ethnicity, because we know from looking at worldwide data and from US data that the rates of certain types of lip clefts do vary in different ethnic groups. So certain ethnic groups have higher rates than others. So it'd be interesting to try to get to the bottom of that and understand why that is. I suspect there's probably a complex interaction between certain types of genetic susceptibilities, as well as certain types of environmental factors that kind of all come together to play a role in why certain groups are more at risk than others. But I think really looking at epidemiological data over a long period of time, and that's what our project is aiming to do, will help kind of clarify some of those factors so that we can understand and help develop preventive strategies among certain groups.
Right. Now, about keloid formation, a lot of African Americans, as soon as you put a knife to some, they will form a keloid.
Right.
Do you find it a difficult problem to be able to not identify, because it's hardly able to identify it, but do you run into those problems where the keloid or the overgrowth of that tissue is almost as bad as the defect itself?
Well, so you're right. I mean, keloid scars are a very challenging problem for reconstructive surgeons, and I think the proof of that is that keloid scars have been around since man has been around.
That's right. Yeah.
Yet we still don't have a totally satisfactory answer to dealing with them and preventing them. They're very, very challenging, and I think one of the reasons for that is because they tend to recur.
Right.
And a keloid is essentially a scar that's just overgrown. So, patients, anyone can have a scar from, I fell down when I was a kid. I have a scar over my eyebrow, but it's hard to see because it healed fairly well.
Right.
But if you had a keloid in that area, what you would see is something very thick and heaped up, and it's very conspicuous and can be very deforming and kind of socially stigmatizing for patients when they get very large, because the bulk of them causes difficulty, pain, a lot of itching. And so one of the things, when we're helping patients deal with these is helping them to understand that not just, like you said, it's not just the reconstruction, but the aftercare is very, very important in making sure that these don't come back. So there's things that we do in the office to prevent that.
Right. Blood groups. Is there any association with a blood group? Maybe you're A positive, B, but with keloid, not keloid formation, but these kind of defects, facial defects.
I don't think that's been looked at closely. I think more the focus has been on some of the possible causative genes. And I think this has been an area of focus because we have so much more information about genes with the completion of the Human Genome Project. So it's just a matter of understanding what those genes do, maybe how they interact with other genes downstream from them, and just kind of putting the puzzle together.
Right. Now, in your trips, you're taking several trips, I understand, into these countries where they don't have proper medical care or surgical care. But have you found that there is any kind of ways they deal with the problem if you don't come? I mean, this is...
Yeah, unfortunately, I think that what happens is patients don't get care. They don't get treated, and they kind of do the best they can in life. I think some patients end up becoming very reclusive because it might be difficult for them to interact socially, and then once that happens, it's difficult to get a job, want to go to school. I think many patients end up getting extremely stigmatized, and I think I don't think it's hard to imagine, because we can even see in our own culture in the United States how differences sometimes aren't always tolerated so readily. So just imagine what happens somewhere else where maybe there isn't the kind of awareness that there ought to be. So
yes. Well, in your travels and getting around the world and seeing all of these things and coming right back to where you have almost all good operating rooms and all the things that get needed to do the surgery, have you developed any new things yourself along the way to deal with some of these things? I mean, when I say that, when you see something that's grotesque, it must give you certain surgical skills that you bring to your back home, even dealing with what we're doing in our own country.
Well, I think what you're getting at is just that with kind of developing certain types of specialty services, which is what we've been aiming to do here at Downstate for several years, hopefully what the end result of that is that because you've kind of put a team of people together, and I've been helping to work on that for several years since arriving at Downstate, basically approaching patients that are particularly patients with cleft lip and palate, approaching them from a multidisciplinary approach, meaning, that means many things. It means, number one, understanding that these are complicated patients. There isn't one doctor or one specialist who possesses all the expertise to help these children get better. And so that you need a group of people,
right,
who all bring their expertise to bear, and that not only are those people helping this one patient, but they're doing it in a coordinated fashion. So everyone is talking to each other. We're making sure that there's a coordinated plan for this child that's individualized for what's going on with him or her, and that we all have kind of an end game in sight that the parents are completely on board with. And we know from years of instituting this approach that this is where the best outcomes happen.
Right.
So I think the degree to which we're able to continue to do that here at Downstate hopefully means that the volume of children that we see with these kind of conditions increases, and then all those things, that you're talking about in terms of kind of surgical innovations happens as a result of that. And not only surgical innovations, but just, intellectual innovations, right? If the more patients that you're seeing and taking care of, the more you understand why they're coming to you, what happened to get them to that point. So it's a kind of a springboard for research, which I think is the key. It's the foundation to everything, hopefully, that you're doing, because it means that you're thinking about outcomes and you're thinking about causes.
With the wars that we've had, chemical warfare, I was involved in chemical warfare during the Korean War and things like this, where Agent Orange and all of these different toxic materials were dropped on people to kill plants at the same time. I look at the Mexican workers in the fields where the fields have been dusted with all of these things that kill bugs and things like this. Has any relationship, or has they seen any greater incidents, or say other farm workers who might be exposed to these kind of chemicals that kill us?
It's an interesting question. So I think the jury is out on that. I will tell you that there certainly is a growing field, and I don't claim to know a tremendous amount about this, but you do see in the literature a growing field of people, again, multiple specialists who are looking at environmental medicine, right? What is the interaction between what, as a group of people, we're exposed to in our environments, and the healthcare results or consequences of that. So I think there certainly are people who are looking at a myriad of exposures. I've seen articles about pesticide exposure and certain types of anomalies. So I think that we're understanding more that we're exposed to many things, and some of those may have health consequences that we need to be aware of.
Because I became very interested in mercury, for example. Among the Spanish folks, they use mercury sometime in the Santeria, the worshiping services, and they actually can buy the mercury right from the botanicas and put it on their breast. They put it around cribs and all of these kind of things. And now they're finding possibly mercury in the umbilical blood as such. So mercury is becoming a great problem. And nobody's really attacking it the way it should be attacked, because when you can buy mercury, and mercury vaporizes, so it gets all in the floorboards of the houses, so you move from one house to the other, you still can have a mercury exposure, not even knowing it because it vaporizes,
Right.
you know. So these are things I've become very interested in when I trained at the University of Michigan, School of Public Health and so forth. We had such a wide variety of so much in the toxic materials that,
Right.
you know, in industry, you know, yes. But I congratulate you for doing all the work you're doing, and I know it must be a strain of body, mind, and soul, and but somebody has to do it, and I'm so glad there are folks like yourself who have committed yourself to doing these kind of things. I know it would be a magnificent thing if we didn't have all these problems what we do, but since time is our enemy, Doctor, but I'm glad to have you here at Downstate Medical Center. And I'm glad that you have a specialty in some of these kind of things and take it throughout the world, you know. But you have 30 seconds to say one more thing.
No, I mean, I think that I would just say that if you can help a person, particularly at a very early stage in life, deal with a health problem that might set them on the road to having a better health outcome, it's extremely gratifying work. And, you know, I think kind of focusing resources on these kind of vulnerable patients
Right.
is very important, because the amount of healthcare resources that are utilized when everything is going right for them are tremendous. So the degree to which we can kind of intervene and help them be on the right track is good on many levels.
Thanks so much for being with us.
Thank you.
And to you folks out there, watch out. You becoming pregnant. It's important to see the early signs of pregnancy and take care of yourself so we can prevent some of these abnormalities. And we'll see you the next time.